Leukemia is the unregulated growth of leukocytes in the bone marrow and leads to altered numbers of circulating leukocytes and marrow failure. Marrow failure decreases the number of RBCs, WBCs, and platelets, leading of course to anemia, increased infections, and hemorrhage. There are many different types of leukemias, but a big help to making the diagnosis, both on your exam and in real life, may be looking at the patient's age. Most of these cancers have a fairly specific age range that almost all patients present within. Let's start by discussing the lymphoid neoplasms. Acute lymphoblastic leukemia or lymphoma, known as ALL for short, occurs primarily in children less than 15 years old. If you get a question with a child having leukemia, the diagnosis will most likely be ALL, because other types of leukemias are much more likely to occur in older patients. The bone marrow is replaced by an excess of lymphoblasts that also spill into the peripheral blood. These lymphocytes are TDT positive and CALLA positive. TDT is a marker for immature leukocytes, and CALLA stands for common ALL antigen and is present in about half of ALL cases. Notice that CALLA has ALL in the word, which is a pretty handy memory tool. CALLA is also associated with a good prognosis. ALL can also be associated with certain genotypes. For example, Down syndrome patients with trisomy 21 are predisposed to ALL. Can you think of a reason why that might be the case? What if I told you the affected gene in ALL was on chromosome 21? Well, that would mean that Down syndrome patients have 3 copies of chromosome 21, where the affected gene is located, so there is a greater chance of that gene being abnormal. A translocation between chromosomes 12 and 21 is a particular variant of ALL that has a better prognosis. Fortunately, ALL is very responsive to therapy, particularly in children. However, the disease can spread to the CNS and testes because ALL cells can make it past the blood-brain barrier and the blood-testes barrier. Chronic lymphocytic leukemia is also known as small lymphocytic lymphoma, and as such is commonly thought of as a type of non-Hodgkin's lymphoma. Remember when we said that the boundaries between leukemia and lymphoma can blur at times? Well, this is one of those times. In contrast to ALL, CLL typically affects patients who are over 60 years of age, and is often asymptomatic and slowly progressive. CLL is a disease of CD5 and CD20 positive B cells. As you can see from this image, these cells are excessively fragile and often disrupted during preparation of peripheral blood, like smears on a slide. This excessive fragility gives rise to the name smudge cells. Smudge cells are not unique to CLL, they are just more commonly seen in CLL. You can note these smudge cells here and here. Interestingly, CLL has been associated with warm autoimmune hemolytic anemias, as we spoke of earlier. Hairy cell leukemia is a rare type of B-cell tumor that tends to affect the elderly, although you can occasionally see this in middle-aged people. There are basically 2 topics that are most frequently addressed on your test about hairy cell leukemia. First, can you see the hairy appearance as the membranes form blebs on the outer surface of these cells? This should be a clear sign if this smear is given to you on your exam. And second, the hairy cells stain positive for tartrate-resistant acid phosphatase, otherwise known as TRAP. It would be very much like the style of a USMLE question to give you this photo and eventually ask what stain would be positive. And of course, you would know the answer would be TRAP. The treatment for hairy cell leukemia is cladribine, which is an adenosine analog that inhibits adenosine deaminase. You will often get a dry tap from bone marrow aspiration because the disease causes bone marrow fibrosis, and thus there's nothing to aspirate on a tap. Name 2 cells that stain positive for TRAP. One I just gave you, hairy cell leukemia, and the other is the osteoclast bone cells. Now let's discuss the myeloid neoplasms, AML and CML. Acute myelogenous leukemia, or AML, primarily affects adults, with a median age of onset of 65 years old, although it occurs across the entire age spectrum. Symptoms arise due to the replacement of normal bone marrow with leukemic cells, leading to a decrease in RBCs, normal WBCs, and platelets. There are several features of AML to be on the lookout for. First, there will be a large number of myeloblasts on the peripheral smear. Second, there is one histologic subtype, which is known as M3, or acute promyelocytic leukemia, which is commonly tested on your exam. APML involves a differentiation block, such that immature cells are unable to differentiate past the point of the promyelocytic stage, and there is an incredibly large number of circulating promyelocytes. The reason you need to know about this subtype is because you can treat these patients with all-trans-retinoic acid, ATRA, or vitamin A. Vitamin A induces the promyelocytes to continue differentiating, eventually becoming normal neutrophils. How cool is that? Taking a vitamin can cure cancer. Risk factors for AML are exposures to alkylating chemotherapy, radiation, myeloproliferative disorders, and Down syndrome. In these AML smears, you should be able to see that leukemic blasts contain dark purple needles in their cytoplasm that are peroxidase positive. These come up all the time on your exam. Can you recall the name? These needles are called hour rods. If you see hour rods in your exam, you know you're looking at leukemic blasts. And if the exam is showing you a lot of leukemic blasts with hour rods, you should immediately know that they are trying to get you to think of AML. Hour rods are most common in our M3, or APML type. These crystals are made up of fused lysosomes, and spilling the contents from these lysosomes can induce disseminated intravascular coagulation, or DIC. Patients can either present in DIC, or DIC can be induced when chemotherapy is initiated. The last leukemia that we'll cover today is CML, or chronic myelogenous leukemia. Is this a disease of older or younger individuals? Well, the median age of onset in this leukemia is between 50 and 60 years of age, which means you'll most commonly see it in this age group, although peak incidence is between 45 and 85 years of age. I'll leave it to your judgment if you want to call these age groups old or young. As CML is a disease of myeloid stem cell proliferation, on histology slides, you will see myeloid cells in varying stages of differentiation, ranging from the larger promyelocytes and metamyelocytes to the smaller, more differentiated cells like neutrophils and basophils. Because the cells in CML are immature and not actively fighting infection, what marker of mature or active myelocytes would be very low in CML? That would be leukocyte alkaline phosphatase. Again, this is a major differentiating factor of the leukemoid reaction that we saw earlier in this chapter. Remember the genetics of CML from the oncogenetics in the pathology chapter? CML is one of the great success stories for cancer research. It is unique in that the cancer is defined by a major translocation between chromosomes 9 and 22, which has been given the name the Philadelphia chromosome. This translocation creates a fusion gene between the BCR and ABL genes that overexpresses a constitutive tyrosine kinase, which plays a role in increasing cell division. The discovery of this overactive tyrosine kinase allowed scientists to develop a targeted therapy against it. This therapy is called imatinib. Imatinib has been found to rapidly reverse the disease course in a majority of CML patients. Be sure to know the association between CML, BCR-ABL, translocation 922, imatinib, and the name the Philadelphia chromosome, because all of these names will appear on your exam in either the question stem or the answer choices provided by the USMLE. Unfortunately, after some time on imatinib, the cancer will often develop escape mutations, rendering the drug ineffective. Other drugs are currently being developed to counteract these escape mutations. Another danger with CML is the blast crisis, when this chronic leukemia transforms into AML or ALL. Blast crises are characterized by a rapid increase in immature lymphocytes or myeloblasts. Before moving on, one last clinical pearl in leukemias. When you have a ton of white blood cells proliferating, and then you initiate treatment, so a bunch of these cells begin to die off, what do you worry about? Well, one would worry about tumor lysis syndrome. This occurs because you have tons of purine breakdown, which is then broken down into uric acid, and this can cause kidney stones. So to prevent this problem, before initiating chemotherapy, you want to give a xanthine oxidase inhibitor to prevent all this excess purines from causing a problem in the first place. Most commonly, we use allopurinol, febuxostat, or if it's really bad, resburicase. Okay, almost there. So here we're going to summarize the chromosomal translocations that are found in various hematological cancers. These are commonly tested and extremely important for your exams. Try to name the associated disorder as we go through each translocation. We'll start with translocation 922. That would be the Philadelphia chromosome that we just spoke about, and our old friend CML. A good memory tool for this is Philadelphia creamel cheese, or cream cheese. Try translocation 814. That would be Burkitt's lymphoma, and the gene product here is c-Myc. Translocation 1114. That is mantle cell lymphoma and the activation of cyclin D1. Translocation 1418. The association here is follicular lymphoma with the BCL2 activation. And last, translocation 1517. This is our M3 type of AML, and be sure to remember that it is responsive to ATRA, or vitamin A.